all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. The discussion today is about this study from Israel, which is large in the size of cohort. The number of myocarditis are lesser still. It's an interesting study. What they are saying is that before the vaccination, so this is March 2020 to January 2021, before the vaccination, the incidence of myocarditis and the risk of myocarditis was not increased in COVID-19 patients, as is the observation and is studied with other studies as well. So that is their um, understanding from the data that they saw. And it is actually correct that if you look at that data as well, it is the same understanding that there is COVID infection did not lead to increased myocarditis or pericarditis. However, I feel that there are two important weaknesses in this study that should be looked at, or we should be aware of it. At the end of the day, they have a data set that shows a result, and we have to accept that. However, we also have to understand where the data set may be not entirely up to speed. So let's start. This is drbeen.com. There is a link in the description that has a very low price of access to Dr. Bean, one-time price. Okay, so with that, this is one study from US, long-term cardiovascular outcomes of COVID-19. We'll discuss this as well. This is from the Veterans Affairs Hospital. This study, the one that I just showed you, has this very elaborate data set. I loved it. I usually do not like these studies, but I loved this one. At the same time, I usually like Israeli studies and UK studies. However, this study kept me a little doubtful. So here is the study. The incidence of myocarditis and pericarditis in post-COVID-19 unvaccinated patients, a large population-based study, 2022 April. And if you see here, this is some of the authors here, and this is a review for this study by the reviewers in MDPI. And I want to look at one part of this together. Then this is another study. This is from Germany, 2020 November. This is a study from Germany about COVID-19 and the cardiovascular outcomes. This few references here are going to be useful as we start our discussion. So with this, let's start the discussion. So COVID-19 and cardiac issues in unvaccinated. So this is an Israeli study. Here is the summary of the study. What they said was, post-COVID-19 infection was not associated. This is directly from the study. This is not written by me. Post-COVID-19 infection was not associated with either myocarditis. So adjusted hazard ratio is 1.08, and it crosses the unities 0.45 to 2.56. That means invalid. Or pericarditis, hazard ratio 0.53, and then it also crosses 0.25 to 1.13. So what they're saying is COVID infection has nothing to do with myocarditis or pericarditis hazard. We did not observe an increased incidence of neither pericarditis nor myocarditis in adult patients recovering from COVID-19 infection. This study was from March 2020 to January 2021. The data was censored from February 2021 onwards. Now, this was a retrospective cohort study, as you see here, and the observation for the patient. So somebody who got COVID-19, they would observe that person for 18 days at least after the 10th day of the infection to 6 months at most. The group sizes 196,992 adults after COVID-19 infection. And in those adults, about 200,000 people, from 10 days to 6 months observation, there were 9 cases of myocarditis and 11 cases of pericarditis. So 20 total cases of myopericarditis in 200,000, about 200,000 infected patients. I'm just rounding these numbers up uh, to give you a quick idea of what we're talking about. On the other side, the control cohort, which was not infected, not vaccinated, with at least one negative PCR and no positive PCR, had 27 myocarditis. So if you see the number 0.0046%, and in the COVID infected similar number 0.0046%, and 52 pericarditis, which is 0.0088, and in the COVID infected 0.0056%. So actually COVID infected lesser. So based on this, they said that there is no difference between these two. Now, looking at the characteristics of the population, which is also very important. So the takeaway I want you to have so far is you saw the data that shows no difference in COVID infected versus uninfected, and they're all unvaccinated. Then they talk about the age, which is 18 plus. Mean age, this is very important to hold this in your mind, 42.4 years. And they put 17 in the, I think that is the range, but they just put 17 there. This is in both groups, infected or not infected. 42.4 years is the mean age. 45.7% were males. And now they said that as age increased, there was an association with more myocarditis. And as the gender was male, it's not that the gender increased, the male gender was also associated with more incidence and risk of myocarditis. And as you can see, adjusted hazard ratio is 4.42% or 4.42 times. So in here, please keep an eye on the age. And the other thing is diagnostic codes. Now let's go to this part of their study. We are still on Israeli study. They say, and I want to actually show you a review of their study where, so if you see here, there are 3 reviewers. The first one says, great job, awesome, great data. The second reviewer says, I have some feedback, one major point and then minor points. In his major point, this person says, why not include codes I40, infective myocarditis, and I30.1, infective pericarditis? Your assumption is that the COVID-19 is the direct cause of the cardiac inflammation for the positive cohort. So they're saying that, hey, you feel that COVID-19 is directly causing the inflammation. Why are you not including infective myocarditis and infective pericarditis? Because it may be possible. So hear this one out. This is a delicate point. Because this may be possible that somebody has the myocarditis after the infection and their doctor diagnosed them as infective myocarditis. So what they did was they responded and they said, so if you go here to the response, they said, in addition, we decided to use the most frequent definitions of pericarditis and myocarditis used in our coding system. Furthermore, in order to specify our results as for acute pericarditis and myocarditis only, we decided to omit the definition of infective pericarditis and infective myocarditis due to the fact that these definitions include bacterial infection, parasitic infections, and recurrent infections. So they actually removed the possibility of a diagnosis of infective myocarditis or pericarditis. And this is where I have my thought here is that if you remove the infective pericarditis and myocarditis, the COVID-related disease, of course, can be put in so many phenotypes, so many reasons, pathologies. There can be autoantibodies, there can be SARS-CoV-2 spike proteins, there can be SARS-CoV-2 direct infection. And when that happens, it really depends how the doctor coded it. So if you said, I only am going to take those codes for myocarditis and pericarditis, which simply means inflammation of these tissues, but I'm going to be selective about it, then it is possible that you have already excluded the data. So here I want to go back to this place. So from this Israeli study, they say diagnostic inpatient codes for myocarditis I40, 40.9, 51.4, and pericarditis 30, 30.0, 30.9 were extracted between 10 days after COVID-19 infection and earliest between 6 months from infection or 28 February, whichever came first. This was done to ensure a minimum follow-up period of 18 days and a maximum of 6 months. So if you look at the codes down here, for your ease, I've put them here. Let's look at the codes here. I30, 30.0, 30.9. So I30 is acute pericarditis. 30.0 is acute non-specific idiopathic pericarditis, meaning we have no idea how this happened, but this person has pericardial inflammation. Then 30.9, they skipped 30.1, which is infective pericarditis. They skipped other forms of pericarditis, and they also then took acute pericarditis unspecified. So anytime a doctor said that I have no idea why this patient has pericarditis, they counted that as a possible pericarditis that could have been by the infection, and then compared that to a non-infected cohort, which also may have had those unspecified pericarditis and myocarditis, and then they said they both are equal. So that means infection did nothing. However, they removed the infective pericarditis or other forms of acute pericarditis, which may have included anything related to, let's say, autoimmune, or where you know that there is a reason for this pericarditis. Look at the I40 codes. Acute myocarditis. Infective myocarditis 40.0 is excluded. Isolated myocarditis is excluded. Other myocarditis is excluded. Acute myocarditis unspecified is included. So for me, imagine we are sitting together, we are doctors, we have patients who have had infection. What we are saying here in this study is we will only include those that got infected, recovered, went away, and then 10 days later or 6 months later had unspecified myocarditis or pericarditis. We will want to count that as caused by the COVID. And if that is more than the non-infected folks, then we'll say COVID caused it. And if that is not more, then we'll say it's equal. So that, I think, is an erroneous way to look at data. Although, let me concede that this is the data they selected. So for their selected data, this is correct, that infected people with cardiac outcomes or uninfected with cardiac outcomes are the same. Then if you look at the right side, I51, complications and ill-defined descriptions of heart disease. From here, they took I51.4, that is here, myocarditis unspecified. So I hope it's kind of clear that they removed the reasons for specific myocarditis or pericarditis, which could be infective or which could be autoimmune as well. They just took unspecified, unknown. We have no clue why this happened. And that is the numbers they compared. Now let's continue. Let's see the US study. So somebody said, "Yikes! No, like, no, it's from before the vaccine." So this is nothing to do with the vaccine, and that is the point. If you look at this study, I believe uh, this study, what they're saying is, if they prove this, although it's a very tiny data point, meaning cohort sizes are large, but data sizes, the event sizes are small. If you take that point, then what they're saying is, if there is any myocarditis increment or pericarditis increment, it must be the vaccine, because COVID infection itself cannot do it, and we can prove it. And I think this, as much as you may not like vaccines or like vaccines, this is from the other studies and from the acute disease things that we have seen and the pathologies that we have seen, it is impossible to say COVID cannot cause myocardial issues. The spike protein and the autoantibodies and the SARS-CoV-2 infection will cause issues. Anyways, so this is their study. Now I want to show you a very interesting thing. So before I go to the US study, I want to show you something that is it was really interesting for me to see. That is this. In this study, the Israeli study, they actually have read the other studies that I'm going to show you. They have read them. And not only they have read them, they actually have a comment on them as well. So here, let's see. Similar to our study, she et al. Showed, so this is the study that I was going to go to, US study, that individuals with COVID-19 infection are at increased risk of cardiovascular complications 30 days after infection, including pericarditis and myocarditis, regardless of the need for hospitalization. Comparable with our study, the study population was tested for the risk of inflammatory heart disease regardless of previous infection or vaccination. Yet, in contrast, in the study by Shi et al., the tested cohort was homogeneous, comprising of US Department of Veterans Affairs with male predominance and young age. So here is the problem I'm going to show you. The difference in the population characteristics may explain the dissimilarity between the results of the studies, as young males are known to exhibit a higher incidence of myocarditis and pericarditis. So keep this in mind, and I'm going to show you the difference between the studies. So I'm going to go back here for a second. Mean age was 42.4, right? This is the Israeli study. Let's go directly to the age for the US study first, then we'll look at the US study. So here is the table 1 from the US study. Look at the baseline characteristics: age, mean, and standard deviation, and then years. COVID-19 cohort, this is US study. Mean age is 61.42. Contemporary control, so they had 3 controls in the US side. 63.46 mean age. Historical control 62.90, and you can also see the standard deviations as well. Now, if you see this mean age, let's say for the COVID infected, 61.42. On the other hand, their mean age is 42.4. However, their claim is that because the US study has more younger people, that is why younger people show more myocarditis and pericarditis. That is why they have a higher rate, which is incorrect. And also, younger population, lesser than 29 or even 34, according to some studies, show more propensity for cardiac issues with vaccine, not with infection. Infection related cardiac outputs are more common. Cardiac output, meaning cardiac issues, are more common as the age increases. And so the age actually is the other way around. And that made me uncomfortable. So maybe still they may have gotten the data set from the Veterans Affairs Hospital and done a more rigorous stratification, and so they may know more. But from the data that we can see, there is a there is an interesting gap in the statement here and in the data. The other thing that is interesting is, if you see here, Puntman et al. Found a 78% cardiac improvement involvement by cardiac magnetic resonance in imaging. And that is this study. This is the Puntman, this is study from Germany. In this study, what they said was that we had 100 patients after COVID, and 78% had cardiac involvement, ongoing myocardial inflammation in 60 patients. Again, this is a very small study, 100 people total. And they have also good rigorous analysis. So analysis is fine in all studies. Israeli studies analysis is good as well. US studies is the most rigorous. I am usually not a fan of the US studies, but this study is good. And then German study has good rigorous analysis as well. So for this study, the Israeli studies author said, however, an important caveat to these studies is the lack of appropriate controls, including patients with other intercurrent viral infections. So, meaning that these studies, the German study that I showed you, and then a few more studies here, their gap is that they have maybe used other myocarditis and pericarditis codes as well. I actually think that this study, Israeli study, has a gap of not using correct set. But let's say, instead of saying who is right and who is wrong, there is a difference in the sets used for the counting. That means these studies cannot be compared apples to apples. And so, if we go back now to quickly look at the overviews, this is the US study. In this study, what they did was they looked at the patients 30 days after the infection and up to about a year. And they looked at development of cardiac issues. And here is the thing. If you read the US study and see how did they make sure that this cardiac outcome is related to infection and not something spurious, something unspecified, they have the positive controls and negative controls, and positive and negative association controls as well, which was amazing to look at. So if I go back here for a second, and if I go to, it takes time actually to pick up all this data and put that together. So first, let's just quickly read this. This is where the US study is saying inflammatory diseases of the heart or pericardium. Look at the US study. They actually are talking about cerebrovascular disorders, dysrhythmias, myocarditis, pericarditis, ischemic heart disease, other cardiovascular issues, thromboembolic issues, additional composite point. Then they did subgroup analysis as well. It is interesting that in the subgroup analysis, for example, if I open this diagram, if you see here in the subgroup analysis, the difference between the age and the cardiovascular outcomes is not too much. But let's go back to where I wanted to go. So here, positive and negative outcome controls. So they wanted to make sure, the US study, that if they think that this is a COVID, post-COVID issue with the heart, then they wanted to make sure that it is the case. So what did they do? They did the following. To assess whether our data and analytic approach would reproduce known associations, we examined the association between COVID-19 and the risk of fatigue, known to be a signature sequelae of post-acute COVID-19. as a positive outcome control. The results suggested that COVID 19 was associated with a high risk of fatigue. So they said, forget about the cardiac issues. Maybe that is spurious. Maybe that's a fluke. So, how about we look at something else that is also associated with COVID 19 sequelae? And if that was positive as well, then that should mean this cardiac issue is possibly a sequelae as well. Then they said, we then examined the association between COVID 19 and a battery of 7 negative outcome controls with no prior knowledge suggesting an association. So then they said, all right, maybe this is a fluke. So maybe that fluke could occur with other events as well. So what they did was they took another 7, and the results yielded no significant association with COVID 19. So it was not a fluke. Then they also did negative exposure controls. The To further examine the robustness of our approach, we developed and tested a pair of negative exposure controls. We hypothesized that the receipt of influenza vaccine in odd number and even number could have a difference as well. So then the results suggested that receipt of influenza vaccine in odd numbered calendar days versus even numbered calendar days was not significantly associated with any of the pre-specified cardiovascular outcomes. So, meaning this was not a fluke, the association that they found. The data sets for both are big. So, if you look at their data set, the US study, their data set is 153,760 US veterans who had infection, then 5.63 million US veterans who did not have infection but were in the same contemporary time um, as the infected ones, but all of them were not vaccinated. So they made sure that the vaccinated folks were not part of this study. So this is also an unvaccinated cohort study. Then they had a historical cohort predating the COVID 19 pandemic. So they took another cohort for 2017, which had no inkling of being SARS-CoV-2 or vaccinated, and that was 5.8 million. So um, Patrick says they did not test for D levels. Yeah, so test for D level. All of these studies have the same issue, so that's a common. So, anyways, now if you see here, unvaccinated. This is U.S. study. They said first, risk of myocarditis and pericarditis without COVID 19 vaccination, because some COVID 19 vaccines might be associated with a very rare risk of myocarditis or pericarditis, and to eliminate any putative contribution of potential vaccine exposure to the outcome of myocarditis and pericarditis in the study, we conducted 2 analyses. First, we censored cohort participants at the time of receiving the first dose. So as soon as you get the first dose, you're censored, your data is censored from then on. And then second, we adjusted for vaccination as a time varying covariant. And both analyses were conducted versus both the contemporary and historical control groups. The results suggested that COVID 19 was associated with increased risk of myocarditis and pericarditis in both analyses. So then I've already shown you the age cohort. And finally, if you see here, pericarditis and myocarditis, that part which was also in the Israeli study, here is the difference. Pericarditis hazard ratio 1.85 and myocarditis 5.38. And they also then said the risk and burdens of a composite of these inflammatory diseases of the heart, pericardium, heart or pericardium was 2. And they also said that as the age changes, it didn't have a lot of huge difference, or sex or um, hypertension, diabetes, that had differences but not huge. And they have given the charts to look into that. There was one more thing that was very interesting from this study, and that was um, pericarditis, risk of burden. There was one more point. Let's see if I can find it here. So this is it. I think I had something in my mind, but I forgot. Anyways, this is the US study. Now, if we look at the German study, this study is also before vaccination. So if you see here, this was actually published in 2020, July 2020. So no concept of vaccines at that time. So July 2020 publication question. So this study from German. What are the cardiovascular effects in unselected patients with recent coronavirus infection? Findings in this cohort study, including 100 patients, as I said before, 78% had the cardiac involvement, 60% had the inflammation. These findings indicate the need for ongoing investigation. Yes, on the US study, they said that the as the severity changed, increasing severity of the disease was associated with increasing cardiac outcomes. So lesser severity, lesser outcomes, greater severity, greater outcome. Both the study, Israeli and the US study, included patients who were not hospitalized or always in this severe. So they had various groups, both of them. So this is the this is the study. It is actually interesting. My request is to do a few things just for your reading pleasure. Number one, in the MDPI, if you go in here and look at the related info and links, you can see the reviewers. So, for example, here I'm going to read this last reviewer. It was actually funny. Reviewer 3 report. The article brings very important data originating from a large population based study. Overall, studies are rigorously performed and the data are convincing. The study limitation sections has answered the queries that I had while reading the manuscript, hence no major comments. So the reviewer number 2 did a very good job of actually saying, hey, why don't you change the title? Why don't you change the lines? Why don't you add this data? They said, how about author affiliations? And so the responses to all of that was also interesting. So this is the study. I hope it makes sense. And with this, I'm seeing sometimes in the comments that there are individuals who are worried that I was infected, I see all these studies, what will happen? Or I was vaccinated, I see all these studies, what will happen? So I want to give them, there are two things we can do. One, we can do a chit chat and just have that discussion. Secondly, I want to give some thought to consider. Of course, I cannot guarantee for anything, good thing or bad thing, but I can only provide some um, medical concept related uh, statements. One is that if someone is going to develop, let's say, a cardiac issue or endothelial issue, then within the infection time or soon after the vaccine, within a couple of weeks, when the antibodies develop, they should start developing the symptoms. This is a um, having disease pop up 2-3 years later just by itself while staying quiet before is difficult. I'll tell you where this can be possible. For example, let's say there is a pancreatic damage and pancreas beta cells are damaged, but whatever is the remaining beta cells, they're working fine. And they could then be reduced as it happens to all of us. Then maybe 10 years earlier than others, the patient develops diabetes. So that is an example of a disease that is latent, will appear later, but was, let's say, because of the infection that it happened. Cardiac issues or the vascular issues are not hidden issues and they would start appearing sooner. So I was responding to someone on Twitter as well that if you haven't right away, and right away being 2 weeks after or 1 or 2 months after, if you haven't developed those symptoms, then 2 years later, you should not start worrying that, am I going to get impacted? So, um, Anyways, if you would like to have more discussion, we can do a chit chat and discuss that maybe tomorrow, day after, or some other day. Tomorrow, I would like to take a day off. I want to go for voting, and I do not know when will I go and how quick I'll come back. So I hope this discussion made sense. Again, with the data sets these studies have, their demonstration of results are correct for that data set. However, there is a huge difference compared to Israeli study and the other studies for the cardiac outcomes. And I'll give you one more thought for why that difference is important to keep in mind. The SARS-CoV-2 spike protein and the SARS-CoV-2 during infection can go around, cause cardiac issues. The spike protein can bind with ACE2 and cause the anti-inflammatory and pro-inflammatory system abnormality. And I have discussed in detail how spike protein can cause damage to the endothelium. So that with the infection can happen in some people. Remember, it doesn't happen in everyone. On the other hand, the most of the vaccines, they have their own mechanisms of the damage. For example, autoimmune can be with SARS-CoV-2 as well. However, it is more common with the vaccines. Spike proteins are locked in 2p format, or pre-fusion stabilized format. That format blooms lesser than an open spike protein from SARS-CoV-2. So that format's effect on endothelium or heart is lesser. Vaccines, more pathogenicity is from the autoimmune or autoantibodies that would attack the ACE2, that can attack the heart, that can attack the vascular system and cause similar issues. So the both can cause issues, but both have other pathogenicity. But this will be very difficult to um, see or to agree on, that COVID-19 infection doesn't do anything to endothelium or heart. That's just impossible. We have seen it again and again for how dangerous that can be. Okay, so with this, there is from here, it doesn't matter you like a vaccine or you do not like a vaccine. This is the data and the comparison of this. Please watch this as well. I know some of the folks will unsubscribe after this, but that's okay. This is the data. And with this, thank you very much. Please like, subscribe, and share. And I would see you day after tomorrow. Tomorrow is the voting day. Go out and vote as well. And there are links in the description if you would like to support this work. You can buy me a coffee, you can use PayPal, you can become part of Patreons or Substack or part of this YouTube channel, or you can get access to Dr. Bean as well. Thank you very much. I would see you day after tomorrow.